It is 5 past the hour, but I'm just going to send a quick tiger text to the attendings because I don't see everyone logged on quite as yet.
I'm very patient, so no worries.
I see some people slowly logging in, so if you'd like to start, Dr. Sloan, feel free to go ahead.
You know what? One of you tell me. We'll give it another minute to allow them to actually join. Make sure they're on. I follow your lead. Ron, you're the master of ceremonies here. Ron, I just got a message on my screen saying something about interference. Can you still see and hear okay?
No, I can hear you. I'm not sure if you can hear me.
Yeah, I can hear you quite well.
Okay. I was saying that people are slowly logging in. If you'd like to start, feel free.
Great. Would you advise we go ahead?
Yes, please do.
Okay, I will. Okay. Well, good afternoon, everyone, and thank you for taking time from your very busy day to join this conference. I'll start off by saying I apologize for not being there in person. Again, I'm not in the area right now. I'm hoping to arrive back in the DC area sometime next week, God willing. Anyway, Dr. Raj actually requested that I talk to you today about new understandings in the pathophysiology of anemia and CKD. So I recently worked at AstraZeneca, and I suspect, perhaps correctly, maybe incorrectly, that actually know something about this topic. But rightly or wrongly, again, we'll plow ahead with this, and again, I'll try to cover some main points here. So, assuming I can advance, which it's not doing right now. Oh boy. Okay. There we go. So again, what we'll be covering today, what I'll be covering today, are the following: anemia CKD. I'll just give you some general background. Then erythropoietin expression in CKD, and what I'll really dig into is impaired oxygen sensing and hypoxia-inducible factor stabilization. We'll then proceed on and talk about the influence of inflammation and hepsiding, and additional effects of CKD and impaired oxygen sensing, the impact that has on iron handling, and then we'll try to summarize. Again, hopefully I can move ahead here. So we'll start out with anemia CKD, and let me give you some general background. So a lot of us, I think, many of you know, or all of you know already, and it's old assumptions and old teachings. But one of the things that's apparent from this is that we all know is that as our patients progressively lose kidney function, and you can see that decline in kidney function going from the left side of the slide to the right side of the slide. On the y-axis is the hemoglobin levels. There's a progressive decrease in the hemoglobin levels. And all of this, we've assumed, and rightly so, is due, and you can look at the bottom figure there, due to reduction in the production of erythropoietin from the peritubular fibroblasts that are located within the kidney. And as those cells begin to transform into myofibroblasts, they lose their ability to produce erythropoietin. As erythropoietin levels drop, there's a decrease in the levels of EPO that are available at the bone marrow level to stimulate pro-erythrocytes, and the end result is a decrease in red blood cell count or decrease in hemoglobin. And of course, what goes hand in hand, and many of us, again, including me, was involved with some EPO research back in the 1989-1991 range. What we've really failed to think about is that what this really translates into is a reduction in oxygen delivery to virtually all of our tissues. Moving forward here. Okay, that's what I have to do. Hold on. So this is an old study from DOPS, the folks at Arbor Research, and it reproduces stuff that you've seen over and over again. It should be nothing new to you. That just highlights it. On the y-axis, you see the stages of CKD, stage 3 all the way down to stage 5, and what it's looking at is the percentage of patients with 3 down to 5 level CKD that have different levels of hemoglobin. And again, the color coding there from the left side of the slide to the right side of the slide goes from 9 all the way up to 13. And what this illustrates is that as kidney failure progresses, not only does the frequency of anemia get worse, but the severity of it gets worse as well. And again, hand in hand with a reduction in hemoglobin levels and a reduction in oxygen delivery to tissue, what one sees is a variety of symptoms that are experienced by our patients. And these are, again, they're lumped here into CNS, to lung, to gut, to cardiac and muscle, but it includes anything from a headache, dizziness, fatigue, cognitive dysfunction, impaired memory, intellectual ability, breathlessness, reduced exercise capacity, some malabsorption, indigestion, irregular bowel movements, tachycardia, angina, heart failure, palpitations, you name it. I mean, there's a lot, and muscle fatigue, just to include everything. So one of the things that I think we all know in caring for our patients in med school and residency and fellowship, and then as attendings, is that there are 2 really key substrates that are necessary to form mature red blood cells. And those include erythropoietin and iron. And again, I have a schematic here that shows the cells that are stimulated by EPO and the importance of iron in differentiation of red blood cells as well, or the stem cells of those. And with regard to EPO stimulation, it's primarily the pro-erythroblasts within the bone marrow that have the EPO receptors on them, and it requires stimulation of those EPO receptors by erythropoietin for those pro-erythroblasts to differentiate into erythroblasts. And respectively, those erythroblasts, it may not be as dependent upon erythropoietin for further development into reticulocytes and red blood cells, but those erythroblasts are critically dependent upon the presence of iron. And if they don't have iron, it's incorporated into the hemoglobin. If it's not delivered to them, there's not adequate amounts of iron, there's not adequate amounts of transferrin. If there's not adequate amounts of transferrin receptor, those erythroblasts will not develop into reticulocytes and red blood cells. And again, I've included here, I just popped it up here. It's really critical to have iron delivery to the bone marrow, but that's dependent upon, again, availability of transferrin. You got to have plenty of it. You got to saturate that transferrin with ferric, that's +3 iron, and you have to have transferrin receptors on the erythroblasts in order to receive the iron and bring it into erythroblasts so they can make hemoglobin. So, again, as much as I just talked about the importance of EPO and the importance of iron, it's a lot more complex than that. And again, this is a schematic you'll be seeing over and over again today, and I'm going to try to go over these categories in kind of bundles. But really to zone in on that reduced EGFR, one of the things that we've really just discovered and became aware of in the past 10 years is that reduced EGFR really translates into a defect in O2 sensing by the kidneys. That is actually what contributes to decreased EPO production. And of course, there's other things that are going on there as well with reduced EGFR, reduced kidney function, the dropout in nephrons. There's a progressive increase in inflammation that increases hepsiding, and all of this contributes to dysregulation of iron hemostasis. Even the decreased O2 sensing contributes to that dysregulation of iron hemostasis. And by the way, I'm not going to leave you hanging with all this stuff. I will describe it. I've even had some of my former colleagues from the University of Rochester. I mentioned, hey, you know about hepsidin, and they said, I think I've heard of it. So I'm not going to leave you hanging. We'll cover all that stuff. But there are other things that are going on here as well, and you're all aware of some of the stuff. Our patients always are, if they're on dialysis, particularly hemodialysis, there's blood loss. In addition, one of the things we know that happens is that people can get AVMs when they gastrointestinal small bowel AVMs and bleed from the gastrointestinal tract related to those, and that's related to chronic renal failure as well. There are uremic toxins that contribute to decreased RBC production. There are other nutritional deficiencies like B12 and folate deficiency. There's shortened red blood cell survival. There's secondary hyperparathyroidism and the inflammation associated with that. And of course, there are medications that we give our patients as well that interfere with their ability to make red blood cells and maybe even contribute to the lysis of those cells. So let's dig in first and talk about the reduced EGFR and inflammation. And I'm going to revert right away to this impaired oxygen sensing in the kidney and decreased EPO production. So again, erythropoietin expression in CKD, impaired O2 sensing, and HIF stabilization. So having problems here on my computer. There we go. So I actually tried to block out the red bar, but I didn't do it. What we expect, if you look at the x-axis here, and you see measured GFR, and from left to right, you're seeing a decrease in GFR. So what one sees, and we just showed this with a decrease in GFR, is that there's a decrease in hemoglobin. What one would expect is predicted increase in mean serum EPO levels with a decrease in hemoglobin levels. You'd expect to see a progressive increase. That's not what we see. We see either no increase or even a decrease in erythropoietin production with decreased GFR and a decrease in hemoglobin levels. So what's going on here? So we know that EPO is produced primarily by the renal EPO producing cells, and I'm going to call these the rep cells. These were previously known as the peritubular fibroblasts or interstitial fibroblasts, and they're now being termed the renal EPO producing cells, or the rep cells. And so again, this is produced primarily by the kidneys, but we also know that the liver produces EPO as well. and contains the expressive genetic machinery in order to produce it, primarily in fetal livers. But even adult human beings are capable of producing and synthesizing EPO from the liver. And I'll just highlight to you, I can almost anticipate a question, because I had the same thing. Is the EPO the same that's coming out of the kidneys and out of the liver? And it's not quite the same. It has the same stimulatory effect on pro-erythroblasts within the bone marrow, but there are slight differences with regard to glycosylation. So one can actually tell where the most of the EPO is coming from by actually doing some SDS page gel analysis and seeing how much glycosylation is present. But irrespective of that, what we know and what we taught for years, that's the old skeleton that's sitting there. Okay, so what we taught and what we thought was that as the kidney function decreases, there's a progressive loss of the rep cells as they transdifferentiate into myofibroblasts and lose their genetic capacity to produce erythropoietin. And the end result is, too bad, there's nothing those kidneys are doing. They're essentially dead. Maybe they're producing a little bit of EPO, but that's it. But what we know now, and again, for those of you that are Back to the Future fans as I am, Great Scott, we actually learned that in addition, we know, fine, that does happen. There is transdifferentiation of these peritubular fibroblasts or rep cells into myofibroblasts, but there is retention of these rep cells far into chronic kidney disease. And it's just that these rep cells are not producing EPO as the kidneys are starting to fail. And the reason we know this, the reason we've learned that it's not the way we used to teach it, is because of actually Nobel Prize winning work that was awarded in 2019. So it just happened, in physiology of medicine. Because of the work of Bill Kalin and Peter Ratcliffe and Greg Simmons, and I think 2 out of 3 of these are, actually, I shouldn't say 2 out of 3 of them. Bill Kalin is actually a nephrologist, and again, so one of our own actually received the Nobel Prize for helping us all understand what's going on with regard to the kidneys and oxygen sensing within the kidneys. So what changes occur with loss of nephron? So again, bear with me with the slide. So the rep cells in healthy kidneys respond to changes in blood oxygenation levels to control EPO production and erythropoiesis. So these rep cells, again, are embedded in the medulla and the cortex of the kidney. And these rep cells typically experience high oxygen demand. And that high oxygen demand, I mean, stick with me here, okay? It's all driven by sodium reabsorption within the tubules. And you all know that we absorb about 98 or 99% of all the sodium that's filtered from the glomerulus into the tubules. And that sodium reabsorption is an energy dependent process and is an oxygen consuming process. So you can envision what's happening here with all of us. Since we filter and we absorb most of the sodium that comes into the tubules, that there's an active process here where we're actively consuming oxygen, or actually burning energy and consuming oxygen because of what's going on with reabsorption of sodium. But oxygen levels actually are pretty well maintained there because it's matched closely with the oxygen supply. There's a very robust vasculature that supplies the kidney. But any slight decrease in oxygen supply to the kidneys, such as would occur in any of us that doesn't have chronic kidney disease with anemia, results in decreased oxygen delivery to the renal cortex, the renal medulla, resulting in tissue hypoxia. And of course, these rep cells are feeling the hypoxia as well. These rep cells then respond to the renal tissue hypoxia by producing erythropoietin. And of course, more EPO produces more red blood cells. More red blood cells deliver more oxygen. And now we're back to baseline. But that's what's happening within the rep cells. They're always sensing the oxygen delivery. And if it drops, they're producing EPO. So why does this happen? This time it worked with a different button. So it all happens because of hypoxia, the hypoxia-inducible factor pathway. This is the oxygen sensing mechanism contained within the renal EPO producing cells that's responsible for regulating physiologic EPO production. And again, it's linchpin to the hypoxic response. I think we have something in here. Okay, so I was hoping that animation was going to work. So HIF is a cellular transcription factor that's responsible for maintaining the oxygen balance throughout the body. It consists of two subunits, an alpha subunit and a beta subunit. And again, I'll highlight to you right now, it's the alpha subunit that is really key to the whole process. But independently, they don't do anything. They don't act as a transcription factor. They need to bind together and they need to form a heterodimer in order to activate the HIF pathway in order to transcribe genes. So activation of the HIF pathway stimulates erythropoiesis, and at the back end of this, you'll learn it stimulates a whole lot more than that with regard to erythropoietic activity. And it results in increased red blood cell production and increased oxygen delivery to tissues. So as I just alluded to, it's the HIF alpha portion under the influence of prolyl hydroxylase, you say, what the heck is that? I'll get into that, and oxygen that provides critical control to transcription. So I want you to look at this figure, and I got to zoom in a little bit on it myself in order to be able to tell you what's happening. So this is the cellular cytoplasm within the rep cell, and you can see the HIF subunit, HIF alpha subunit there, and you can see lots of oxygen floating around. In the presence of oxygen, and the other thing that's floating around is this enzyme called prolyl hydroxylase. So what it does is it hydroxylates proline, the amino acid proline. And in order to do that, in order for prolyl hydroxylase to work and to hydroxylate the HIF alpha, it needs oxygen around. So if there's lots of oxygen around, prolyl hydroxylase takes that oxygen, it hydroxylates HIF alpha. HIF alpha, now again, given the fact that it's got two hydroxy molecules hanging on it, it essentially tags itself and brings itself to the attention of von Hippel-Lindau tumor suppressor factor. What that does is it marks HIF alpha for ubiquitination or for degradation. And you can see there exactly what's happening. It's getting destroyed. And the end result is it gets destroyed before it gets to transmigrate into the nucleus to bind with HIF beta, which is where HIF beta resides. So as long as there's plenty of oxygen around, or it senses there's plenty of oxygen around, HIF alpha gets broken down, and it never really makes it to HIF beta and to form the heterodimer, and you don't get any downstream transcription as a result. Oops. Conversely, in a setting of hypoxia, where there's not enough oxygen being delivered, so in other words, if anemia exists, there's decreased oxygen delivery to the cortex and the medulla, the rep cells sense it, you can see there's a dearth or a paucity of oxygen that's present in that cell cytoplasm in the lower half of that slide. And now you find there's plenty of prolyl hydroxylase there, but it doesn't have its coenzyme, it doesn't have its cofactor of oxygen in order to hydroxylate HIF alpha. And by the way, it's never an all or none thing. I mean, you're always going to have some oxygen there. These are extremes. But in the absence of adequate amounts of oxygen, HIF alpha is not hydroxylated. The end result, it survives to translocate into the nucleus, makes it into the nucleus, it combines, forms a heterodimer with HIF beta, and the end result is now you have an active transcription factor that binds to the hypoxia responsive elements as the HRE. Those are it's a promoter area within the genes to allow for downstream transcription of the erythropoietin gene and erythropoietin. It does a lot more than that as well, and we'll get to that, but hang with me. So this just is a schematic that shows you what happens. So with that combined HIF alpha, HIF beta, that heterodimer, stimulation of the transcription and subsequent translation of erythropoietin, which can now travel to the bone marrow, where it can stimulate the pro-erythroblasts to differentiate to erythroblasts, and of course, whatever else is going to happen downstream. Remember, iron is still important here as well. We'll come to that. So, in CKD, there's impaired oxygen sensing by the rep cells, and that leads an insufficient activation of the HIF pathway in the kidneys and decreased EPO production. The question is, why the heck is this happening, right? So, CKD progresses, that upsets the delicate balance of oxygen supply and demand in the kidneys. So why does it happen? So bear with me. What's happening here is this. So remember, we don't even, I don't know if I want to go back here, but don't look at the slide for a minute, just listen to me. Remember what I just talked about with regard to sodium filtration and sodium reabsorption. But what happens when people develop chronic kidney disease? They're dropping out nephrons. And as they drop out nephrons, their filtration fraction actually decreases. The amount of sodium that they filter decreases. And if there's less sodium that's filtered, there's less sodium that needs to get reabsorbed. Remember, sodium reabsorption is an energy-dependent, oxygen-consuming process. So if you're not reabsorbing as much sodium, you're not burning the energy, you're not consuming the oxygen, and the end result of this is the amount of oxygen that's actually, maybe the delivery is not as great as it was, but the consumption's not what it was either, even in the presence of anemia. So the rep cells, essentially, again, now you can look at what I have down here, is GFR declines, fewer nephrons, tubular sodium reabsorption is reduced, oxygen demand in the kidney decreases. Next bullet, the rep cells sense sufficient oxygen to meet the local demand. The renal tissue oxygen levels are therefore not representative of what's going on systemically with regard to oxygen levels. So to the muscle, to the heart, to the brain, to the gut, you name it, that's not getting adequate oxygen. It doesn't have the same mechanism that's what's going on here within the kidney. But the end result is the HIF pathway is not activated, EPO is not produced, and it leads to reduced erythropoiesis. So I'm just going to restate this again because I think it's critically important. So restated, oxygen requirements in the kidney in CKD decline. The majority of oxygen consumed by the kidney is used for tubular reabsorption of filtered sodium. In the healthy kidney, any reduction in oxygen supply, as would occur with anemia, results in a hypoxic state within renal tissue that activates the HIF pathway. But in CKD, as GFR decreases and nephron number decreases, there's a decrease in the amount of filtered sodium for reabsorption, reduced oxygen consumption, and therefore, despite relative tissue hypoxia in CKD anemia, the kidney perceives a pseudo-normoxic state as oxygen supply exceeds the demand, and therefore HIF alpha is degraded and reduces transcription of genes. So again, I'm going to just dig into this and move forward to show you some evidence. So, I probably should have backed up here. So there's evidence that suggests that even patients that are on dialysis and have really pretty severe renal insufficiency and nephron dropout are still capable of producing erythropoietin. So as much as we talk about, hey, the rep cells aren't around and they're not producing EPO, actually there's evidence to the contrary. And this is a study that's done in patients at different altitude levels. And as you know, as people, as you rise in altitude, the oxygen concentration decreases. Actually, I'm in a pretty low oxygen milieu right now. Maybe that's, you'll say, no wonder Sloan didn't do a very good job presenting as hypoxic. But I'm actually at I'm at 10,300 feet right now when I'm giving this presentation. So this study is, these studies didn't even reach that altitude. So it's looking at, an altitude above sea level, 0 to 1,500 feet above sea level, 15 to about 3,000, 3,000 to about 4,500, and greater than 4,500. And it's looking in this, it's over 1,000 patients in this study. It's looking at what their hemoglobin levels were. These are patients on dialysis, by the way. What their hemoglobin levels were, how much EPO they actually needed in order to get there, and how much IV iron they needed. And what's clear from this is that the higher the altitude these hemodialysis patients were at, the higher their hemoglobin levels were, even though they used progressively less EPO, exogenous EPO, and it also shows that they needed less IV iron. So there's something going on here. I mean, it should be telling you that these patients, again, even with severe chronic kidney disease, appear to have the capability of generating hemoglobin with lower exogenous amounts of iron, lower exogenous amounts of erythropoietin. Another study, and this is a basic study, I should say a laboratory study, laboratory animals, where I was tripping on this guy's name. It's Priyad Arshi and his colleagues. And what they did was they looked at rats where they did remnant kidney models, so they did 5/6 nephrectomy, and then they did sham operations on the other ones. And what they did was they measured the oxygen content in the cortex and the medulla of the animals that had remnant kidneys and those that had normal kidneys that just were sham operated, didn't have anything done to their kidneys. And what you can see here in the figure on the right-hand side is, and it's the gray, those are the rats with normal kidney function. If you look at their O2 sats in the cortex and the medulla, are lower than they are in the remnant rats. And it comes back to the same thing we were just talking about with regard to physiology. There's reduced sodium filtration, reduced sodium reabsorption, reduced energy, reduced oxygen consumed. And the end result is in these tissues where the rep cells reside, O2 concentration is actually just fine. And that's what's shutting off EPO production, or not turning it on, I should say. And this is a simulation model that looks at, again, there's an X, Y, and a Z axis here. And what it's looking at is the O2 concentration within the kidney, dependent upon how deep you are within the kidney. And of course, the deeper you go, you figure the less oxygen. And what the filtration fraction is. And the values here, it's going closest to you is higher filtration fraction. So more 20%, which is normal, all the way down to 0.2. But more sodium is being filtered at the 0.2, at the one closest to you. And what it's illustrating to you is the deeper you go within the kidney, and the more filtration fraction that occurs, okay, so we're bringing down to a point here, the lower the tissue O2 sat. Okay, so it's a simulation model. But it illustrates to you, similarly, that if there's less filtration fraction that would occur, as would occur with chronic kidney disease and nephron dropout, and certainly the deeper you go within the kidney, or I should say the less deep you go within the kidney, the more the less oxygen is going to be consumed, and the higher the tissue oxygen levels. So let's leave that for a minute. Move forward. I don't even know what time it is. Hopefully we're moving okay. Ron, we're doing okay? Hope I haven't put you to sleep. Okay, that's good. It's good to know you're still awake too. That's good to know. Okay, so what's the influence of inflammation and hepsiding? So we'll move on to that. And again, this is the same schematic. With reduced EGFR, there is an increase in inflammation. And I think this is apparent to all of you. When I was working back at the University of Rochester years ago, was very interested in NADPH oxidase, and it was apparent that NADPH oxidative stress actually increased progressively, at least with that particular model, NADPH oxidase, from 30 mLs per minute of GFR all the way down. But you can see from this study, and this is in patients, it's looking at CRP, C-reactive protein, interleukin-6, and TNF-alpha, tumor necrosis factor alpha. And it's apparent here with all of these that as there's progressive decrease in kidney function, and that's going from the left side to the right side for all of these figures, there is a progressive increase in CRP, IL-6, and TNF-alpha. So progressive increase in inflammatory state or inflammatory biomarkers. In another study, and this was a laboratory study where they did IL-6 infusions in 6 normal patients, and you can see from the figure on the left-hand side with infusion of IL-6, and it went on for a period of 3 hours, and then they shut it off, and then they measured the IL-6 levels up to 2 hours. You can see what urinary hepcidin levels do. So with beginning infusion, there's a progressive increase in hepcidin levels. And by the way, we'll get to what hepcidin is here in a minute. You can dig into that a bit more. Progressive increase up to 2 hours after the infusion, and it's only 24 hours later that there's a progressive decrease. But even then, it really, for a lot of these patients, didn't even reach baseline. So what is hepcidin? Hopefully I can progress here. Not progressing. Come on. Go. Okay. Hepcidin is a small peptide made in the liver, and it's the master regulator of iron homeostasis. And I should have broken this down a bit more, but initially pay attention to the left side of the slide. So in normal status, in you and me, assuming neither one of us has chronic kidney disease, we have these channels within our cells, within the macrophages of our cells that are in the reticuloendothelial system, within the enterocytes, and within the hepatocytes, something called ferroportin. And they allow that channel, if you will, allows for transporter, allows for iron that resides within macrophages, within enterocytes, within the small intestine, and within the hepatocytes to move whatever iron is present in the cells out of the cells. And of course, that's important for iron mobilization. With inflammation, though, that occurs with chronic kidney disease, and I'll also point out that hepcidin, being the small peptide that it is renally excreted. So as you lose kidney function, you lose your ability to actually get rid of hepcidin. So levels begin to increase. You got two reasons why hepcidin levels are high. But what hepcidin does is it causes degradation of the ferroportin. And the end result of that is if you don't have a channel by which to move the iron out of the cells, in the macrophages and the enterocytes or hepatocytes, no matter how much iron is present in the cells, it can't get out. It's sequestered. And so elevated hepcidin levels, again, will result, and I'll show you this in a minute, it's from the same study, from the IL-6 study that I just showed you. It results in low serum iron, as you expect, low transferrin saturation, since iron can't bind to transferrin, it's not getting out of the cells, and normal to high ferritin levels. I mean, ferritin levels unexpectedly high because storage iron, it goes up. And that's termed functional iron deficiency. And for all the nephrologists that are on the phone here, I mean, or in this meeting, that's a very familiar term. So hopefully we can move forward here. So this is the same study I showed you with IL-6 infusion and increase in hepcidin, but was also shown in that study, their key was to say, what can we illustrate clearly, proactively here, what happens when we jack up interleukin levels and increase hepcidin levels, what happens to serum iron, and what happens to transferrin saturation. And you can see there is a progressive decrease that occurs as hepcidin levels went up and inflammation occurred with the IL-6. So again, illustrating proof of point that, again, hepcidin levels decrease iron availability and iron saturation. So this is another study. Not only it looks at hepcidin levels in healthy controls, that's all of us. You can see where we reside, but it also shows you here as we're moving over into the right-hand side of the slide, 100 ml per GFR down to 0. As people lose kidney function, there's a progressive rise in their hepcidin levels. And again, as you're losing kidney function and ability to get rid of hepcidin, number one, and number two, the inflammatory state is stimulating hepcidin. So the other piece of this is there are other things that are actually going on with inflammation as well that impede or impair erythropoiesis. And again, I just highlighted these or bolded these on the left-hand side of the slide, and I made them in red in the figure there. That inflammation actually, of and by itself, suppresses endogenous erythropoietin production. It impairs proliferation and differentiation of erythroid precursors, and it actually decreases the lifespan of red blood cells. So again, you got a multifold process going on. So the last piece of this, additional effects that chronic kidney disease and the impaired oxygen sensing that comes with it have on iron handling. So there's a whole lot more that goes on other than just EPO production and the influence on ferroportin. So we'll come back to my schematic here: reduced GFR, impaired oxygen sensing, and an additional means by which dysregulation of iron hemostasis occurs. This is the same thing I showed you earlier, okay? Only, again, in the state where hypoxia would normally occur and where HIF-alpha transmigrates or translocates into the nucleus and binds with HIF-beta, not only do those hypoxia-responsive elements, HREs, stimulate the erythropoietin gene, but there's a whole series of genes that are involved actually in iron homeostasis. Now, again, put your seatbelts on for this one, because this slide's going to take us a little time, but bear with me with this as well. Okay, so starting at the top of the slide here, you see the HIF-alpha, HIF-beta dimer, and the stimulation of the hypoxia responsive elements and target genes transcribed. I'm going to start over on the right. I don't mind right from left. The right-hand side of the slide here, and we'll just start out within the duodenum. Again, this is all iron metabolism, guys and gals. So, number one, so you ingest iron. You know, whether it's iron that you're taking that's in your foodstuffs, or whether you're taking metallic iron, okay, elemental iron. Either way, the iron is only absorbed within the ferrous or +2 state, and most of the iron that is, not all of it, but a good part of it is ferric, which is +3. So ferric iron needs to be converted to ferrous +2 iron, and that happens under the influence of duodenal cytochrome B. That's the DCYTB, duodenal cytochrome B. So that actually is one of the genes that's stimulated, or one of the proteins that's transcribed by HIF transcription. Okay, so that is enhanced with HIF transcription. So one, you're now making a form of iron that is better absorbed. Number two, the other protein that is stimulated, whose expression is enhanced, is a divalent metal transferase 1, that's the DMT1, and that's the enzyme present in the enterocytes responsible for absorption of +2 iron. So that's stimulated. But again, I just highlight to you, none of this, if HIF-alpha doesn't hit HIF-beta because there's a perceived normal amount of oxygen that's in the cytoplasm, none of this is happening. Again, that's key to keep in mind. But let's proceed. The other protein that's expressed, or receptor, I shouldn't say receptor, transporter that's expressed, is ferroportin. So the very transporter that's responsible for transporting iron out of the enterocytes is also enhanced in the presence of HIF stabilization. So that's just the enterocytes. Let's move over to the liver, okay, the reticuloendothelial system and the macrophages, okay, that they normally store iron. And there too, the expression of ferroportin in those cells will be enhanced with HIF-alpha, HIF-beta dimerization. And the other thing that's enhanced is ceruloplasmin. I know, again, the only thing, well, that's Wilson's disease. No, ceruloplasmin is actually responsible for conversion of +2 iron back into +3 iron. So once iron is transported, +2 iron is transported by ferroportin out of the macrophages, out of the hepatocytes, into the plasma milieu, it needs to be converted back to +3, and that's where you need ceruloplasmin to do that. And that +3 iron is the form of iron that transferrin binds to. And lo and behold, transferrin is also enhanced. This expression is enhanced by HIF stabilization. And then, so again, all these things are coming together, right? And then lastly, the other protein that's expressed by stabilization of HIF is the transferrin receptor within the bone marrow. So you put all this together and we come down to this. I mean, all this facilitates iron, delivery to the erythroblasts. Remember we talked about the pro-erythroblasts are responses to erythropoietin and erythropoietin receptor. That's not true for the erythroblasts. They really need iron. If they don't have iron, they're not going to continue to differentiate into reticulocytes. So having all of this come together, right? Increased iron absorption, increased mobilization, increased transfer to the erythroblasts, and the fact that there's increased transferrin receptor to bring that iron brought to it by +3 iron bound to transferrin, all comes together and again results in a coordinated erythropoietic response. So there's one other thing that's important here, and there are actually some indirect effects of HIF on hepcidin, iron mobilization, and the availability of erythropoiesis. So it just so turns out that erythroblasts, and again, it's important to highlight here that EPO does this, and HIF stabilizers do this as well. And this talk is not about the therapy. Dr. Raj asked me just to stick to my guns here and talk about pathophysiology. But the other thing that's produced by erythroblasts is erythroferrone. And it appears some of this enhanced production of erythroferrone by erythroblasts must have something to do with the fact that there's increased iron delivery to the erythroblast, enabling increased synthesis of that erythroferrone. But why do I mention erythroferrone? Because erythroferrone actually inhibits hepcidin production by the liver, which is key. So you got another mechanism by which to shut off hepcidin to improve the expression of ferroportin now within the enterocytes, within the macrophages, within the hepatocytes, to mobilize the amount of iron that's present there and improve the delivery to the bone marrow. I'll add one more thing in here, and that's not in the slides. One of the other things, and again, this is I'm trying to remember who did the studies. It's a guy out in California, UCLA. But he's actually been able to demonstrate that increased monovalent and divalent carriage of iron by transferrin also shuts off hepcidin. Conversely, increased free iron actually increases hepcidin. And actually, it's teleologically, that's probably why hepcidin developed. It's to shut off if there was an inflammatory state, there'd be increased free iron that would be available. By the way, all bacteria need iron in order to grow, and by shutting off access to extra iron with hepcidin, it'd be a way of actually starving bacteria, and it's an antibacterial effect. So teleologically, that's why it probably works, but it's a whole different conversation. So anyway, this is in summary, okay? Failure to activate the HIF pathway in CKD has cascading negative effects on erythropoiesis. And it has all these effects, not only on erythropoietin, which is on the far left side of the slide, but DMT1, duodenocytochrome B, ferroportin, ceruloplasmin, transferrin receptors, and all of this is going to go away, of course, if you don't stabilize, or if you have abnormal oxygen sensing by the kidneys because of those rep cells sensing that everything is just fine. So again, multiple factors are contributing to anemia CKD, not only blood loss, uremic toxins, nutritional deficiency, medications, secondary hyperparathyroidism, shortened red blood survival, but all the things we really dug into, which is really the new stuff that you really need to consider in patients. That reduced reduced GFR actually, and reduced nephron number translates into impaired oxygen sensing by kidneys. It still have the capability of producing EPO, decreased EPO production, dysregulation of iron, all this inflammation is going on, and increased hepcidin. And I'm just going to add one more thing. I got contacted by, I do some, several of you know this, consulting, and apparently some protease inhibitors used for HIV disease actually decrease hepcidin levels. And there's a group trying to get any pharmaceutical company interested in latching onto this and doing something with it, because it's something that may actually benefit our patients as well. So I'll just finish up by saying that, again, impaired oxygen sensing in the kidneys and dysregulation of iron hemostasis plays a major role in anemia CKD, and oxygen sensing, the oxygen sensing HIF pathway really is a key regulator of erythropoiesis, affecting both reduced endogenous EPO levels, iron absorption, and mobilization. And with that, unless I can think of something more to say, with 5 minutes left, I'll finish and say thank you and receive any questions you might have. Assuming everybody's still awake.
Dr. Sloan, I just have a comment to make. I think it's very interesting, that observation that with the decreased, GFR, there's less oxygen consumption by the kidney. And it's something, I guess, as a fellow training, is something I've never considered. But it definitely is something that's interesting to notice, because these patients with CKD are often the anemic patients. So, that probably is the premise behind them not requiring a higher hemoglobin goal as well.
Yep, and you're not
correct
alone.
to think of that? Yeah.
You're exactly right. I mean, it's you're not alone. I mean, all of us have thought that. That's what I'm saying. I had that skeleton on there, with the stethoscope and the white coat. That's what we've taught for years, right? That it's just we haven't recognized what the true pathophysiology is, and of course that's why Nobel Prizes were handed out to these guys in 2019. We didn't know about it, but I mean, knowing what we do now, I mean, it's inherent upon us to figure out better ways. And I'm not saying there's any particular way to do it, but for all of us to start thinking about other ways, including these protease inhibitors, right? That again, none of the major pharmaceutical companies wants to pick up, that may actually have some impact on hepsiding, right? If nothing else, even if it doesn't address the oxygen sensing problem. So yeah, so you're not alone there. So.
Yeah, it's appreciated. Thank you so much for the talk.
Sure.
This is Oscar. Can you hear me?
I can.
All right, awesome. Thank you so much for that. That was fantastic. I'm going to ask you to, break out your crystal ball. I know today's talk was mostly about pathophysiology and not about the therapeutics, especially since there's a certain amount of speculation surrounding future approval of certain agents, particularly your HIF-PHI agents. Do you anticipate that there will be commingled use of the recombinant erythropoietin as well as your HIF-PHIs, or do you think that should approval come, that there will literally be a replacement or direct competition?
And actually, I'll tell you, as soon as you're asking me a question, I start shaking in my boots because I figure he's going to really stump me with this one. So you give me an easier answer. Thank you. Anyway, I should have disclosed up front. Again, I just forgot to do it, and Rohan, I apologize for not having a disclaimer thing. So as I say, I used to work for AstraZeneca. I worked for them for a little over 2 years, and worked on prolyl hydroxylase inhibitors, specifically roxadustat. So again, actually, thank you even for asking the question, just so I could make that disclosure. I don't work for them anymore. I have a little bit of stock, not much, and primarily I work for other small startup companies. But all that said, I'll give you some background. So one, there are several HIF prolyl hydroxylase inhibitors that are already approved on the market, not in the U.S., but for example, roxadustat, vadadustat, and daprodustat, I think, are all approved in Japan. I know that roxadustat's approved in China. It was the first place it was approved, and it's also approved in Brazil. Chile, and I think it just got approved in the EU. So it is being approved in places. What I think, and again, I'm trying to give full disclosure here and make sure the fellows and everyone else on the phone is up to speed on where we are, where things are with these drugs. So I'll just, and if I'm digging too much into this, actually tell me. But I initially, again, there was a big presentation at ASN in 2019, I think, before all the papers came out, and it looked as though, I mean, the concern with EPO obviously is MACE, major adverse cardiovascular events, and that's what everyone, started tucking back their use of EPO because of, me included. I mean, I was involved in the original studies back in the 1990s, and I used it like water. Used it on my dad who had kidney failure. Used it on my aunt who had kidney failure. And I primarily was the primary user of it and trying to get people to normal hemoglobin levels. And we discovered, MACE is an issue. We thought originally, based on the analysis that was done by Fibrogen, roxadustat, that the major adverse cardiovascular events in incident patient population were significantly lower, as was cardiovascular hospitalization in that patient population. And, in full disclosure, in April, they came back to the FDA and said, oh, what we submitted to you a year ago wasn't right. That was post hoc analysis. It wasn't the pre-specified analysis that we promised you. And actually, the results didn't show any difference between use of EPO or HIF prolyl hydroxylase inhibitors. So that said, and the FDA actually now wants more data. Other ministries of health are approving the drug. So coming back to your question, I do think, as much as I think we all hope that we'd see improved MACE results because potentially EPO levels with these drugs were lower, and maybe EPO was causing some endothelial damage or doing something bad to the cardiovascular system. There does appear to be, I'll just say there are clinical benefits that actually can be offered with these drugs because they are oral. So in the CKD population, not on dialysis, that don't have an infrastructure by which they can receive iron, by which they can receive parenteral EPO, there's an advantage. They have something. So I think there's the population where it'll be used. Number two, currently, as you well know, we are stuck in a lot of patients that have functional iron deficiency, and we keep giving them IV iron. And we look at the pivotal study in Australia, and we say, oh well, we got to give people tons of iron. Well, that's using the old paradigm. One wonders what happens if one doesn't have to give all that iron. You just can mobilize what you already have and enhance absorption of existing iron that you can take orally. So I do think there's a place for this. I don't think that for big LDOs, for example, to totally convert over to from what they've been using for years and have algorithms down for. I'm not sure we're going to see that, but I think that to answer your question, there will be use of both agents by LDOs and by practices around the world for reasons of convenience and for reasons of functional iron deficiency and hyporesponsiveness to EPO. The long answer to a short question.
Thanks very much. No, yeah. That's excellent. I appreciate it.
Hi, this is Susie. Thank you for a wonderful presentation. I wanted to ask.
Shaking my boots against you, Susie.
Hi. I wanted to ask you a question on whether there is data on dialysis patients who exercise versus who don't exercise, whether their response to HIF prolyl inhibitors are different in their response.
And I'm going to ask you, why would you think that they would be?
Because it depends on their exercise tolerance, if they become short of breath or not when they exercise. So if they exercise and they get hypoxic, quote unquote, that they may respond differently.
But the key, and actually, I'm glad you asked that question because I think it's a clarifying question. So remember, I'll say there's no data that I'm aware of that that there may be a difference in responsiveness in exercising versus more sedentary patients. On the other hand, the key element here is to remember it's not in the muscles, it's not in the myocardium, it's not in the brain. All those organs are saying, feed me, we're not getting enough oxygen. But the kidneys, it's all linked to sodium, right? Because the kidneys are perceiving since there's not a lot of sodium being reabsorbed, there's not a lot of oxygen being consumed there. And even when they're running or doing the treadmill or on the bicycle in the hemodialysis unit, their kidneys are still not changing the amount of sodium that's getting reabsorbed. And the end result is in the medulla and the cortex of the kidney, it's still putting back and saying, we got plenty of oxygen, right? We don't really need to turn on the HIF pathway. So one, intuitively, I wouldn't expect that you would see a difference. But number two, I can't say that I can pull that data out of my pocket.
So what you're saying is that in patients on dialysis, because they don't have kidney function or their kidneys are not viable, that their response to oxygen and the HIF inhibitors will be fixed, that it won't fluctuate.
That's correct. And again, it's important to keep in mind here, it's even in our patients that start dialysis and our patients who are on PD who have more kidney function, but even patients on hemo, there's still some, the nephron, as long as there's still nephrons there is the potential of rep activity and HIF activity, HIF pathway activity, and actually turning on the whole HIF pathway, stimulating EPO and all those iron mobilizing mechanisms. But it's and certainly once people become anephric or they lose their, say they have a nephrectomy, their ability to make EPO from their kidneys is really going to be reduced, oxygen sensing or not. But even then, I'm going to point out, with a lot of these patients, and I think some of the studies, I'm going beyond your question, I think, here a little bit, but it's important to recognize that there's probably some hepatic metabolism or hepatic generation of erythropoietin, again, stimulated by these agents.
Dr. Sloand, can I just ask you a question about anemia post-transplant? You can hear me, correct?
Yes, I can.
Yeah. So we often see, in fact, we do see anemia and EPO dependence persist post-transplant. And there was this paper from Greece, I believe. I can't remember when it was written. It must have been in the last 5-10 years, that showed even in living donor transplant recipients, a large percentage of patients were still EPOGEN dependent, exogenous EPO dependent, even 24 months out from transplant. So assuming there's truth to this, I'm sure there's truth to this theory about the HIF stabilization and this perceived oxygen, presence of oxygen that stops the production of erythropoietin. That would effectively be eliminated if you have a functional allograft which is consuming oxygen, which is handling sodium. But yet anemia persists. So do we think that the reason anemia persists in those patients is because of a hepsidin issue, because of the inflammation, or do we think it's the bone marrow suppression from the transplant medications, which is overriding the HIF stabilization theory, which would theoretically be rectified if you have a functional kidney? Do you make sense?
Yeah, it does. It's and Ryan, I'll just start by saying it actually, all this stuff is true. They don't hand out Nobel prizes to right. So it's true. That's one. Number two, I should have known, and I will know next time, knowing that we have as many transplant focused folks on the phone, I should have dug into this and pulled out data, whatever data I could find with regard to transplants. And I know that the transplant patients post transplant can be anemic, and I know there's also a population that's polycythemic, right?
Mm. Right. Some people. Yeah.
But specific to your question, why it is that certain individuals post-transplant, post-renal transplant, continue to have anemia, I don't know the answer. Certainly, you mentioned one, they're on immunosuppressive drugs, whether those are contributing to it. Number two, whether ongoing inflammation is present. A lot of these patients don't have normal kidney function. They continue to be inflamed for one reason or another. And, that inflammation can contribute to ongoing hepsiding release and inhibit iron delivery to the erythroblasts. Number 3, I don't know what the state, if an organ's been harvested, if there's any ischemia time. I don't know how sensitive, for example, the rep cells might be to drop out in cold perfusion, warm perfusion, whatever else. I just don't know the answer to that. I'm raising more questions than I'm raising answers. And then the other piece of this is what is the sodium reabsorptive capacity? Is it, and maybe you'd be able to answer this, is the sodium reabsorptive capacity in a transplant with identical amounts of GFR similar to someone who doesn't have a transplant? So at 30 mLs per minute with a transplant versus your native kidney function, what's the sodium reabsorptive capacity? Is it the same? If it's reduced in any way, it may ameliorate the oxygen consumption, reduce oxygen consumption, and placate those rep cells who then think everything's just fine, there's plenty of oxygen.
Right. Objectively, I don't know, but certainly it would be more sodium resorption that's happening after a functional graft than there was before. So,
all interesting. Yeah, go ahead.
Yeah. So, I mean, like just based on that, you would think, okay, so that's one, bit of the equation that that's preventing EPO production from being made. That's one, issue off the table. But lo and behold, the anemia persists. That's why I just think it's interesting that that even some people with with surprisingly good GFRs, like some people leave 1 to 2 months later, they have a creatinine of 1.0, 0.9. They're making lots of urine, and so they have excellent allograft function, but yet they're still needing epogen. So I just think it's interesting that that despite that,
and actually, I just if anybody's interested, again, you're doing research, others are doing research. One, dig out, find out what data is already there. If it's not already there, those are some questions that need to be answered.
Right. Yeah. But thank you. Yeah.
No, no problem. Other questions?
I think a few people logged in, but then had to leave early due to commitments at 5 o'clock. But thank you so much for the presentation.
Is there a gathering there, by the way, or no? Is everybody remote?
Everyone's remote. I sent a notice that that this was being done via WebEx. But no, we really appreciate. But we really appreciate it, and with your permission, Dr. Sloand, I might upload the slides on our website if that's okay, and perhaps you can. You can. Yeah. Okay. Sounds good. All right. Thank you again. Thanks, everyone.
Thank you for your presentation. Bye-bye.
Thanks, Susie. Thanks, guys. Bye-bye.
Thank you.